actually going to mention this morning too, a historical context. A couple of you may appreciate that. And the rest of you want to know, what's on the test next week? Because the final, we don't know what's on the final. Well, I can talk about that briefly too. Thank you very much. Thank you to the gentleman who we actually see over in the Health Sciences building a lot. It's a nice day to walk across the campus. I am not going to try to take attendance because if you're here, and you're getting the class, and we have all of 2020 invited to the class. And if you're not here, maybe somebody can take. It's fine with me if you do, or look on get some alternative means of getting the information. Okay? So for those of you who are here. Today we're going to talk about competency number 12, and we started it last week. So this is your last class for Nursing 2020. You will have your final exam next Wednesday in your regular rooms at your regular time, where you're comfortable and used to your spot or your lucky seat or whatever it is in your regular classroom at your regular time. And we will give you plenty of time. We'll give you, starting at 9 or maybe a few minutes after, you'll have a full 2 hours to do 100 questions. It's 100 questions, all multiple choice, no alternative format or dosage calculations. Part of that is for our convenience, so that we can run those scantons through the machine and get your scores, and not have to hand grade things during the middle of the finals week. With the hope, then, that we can get ready to post your scores. The other little complication, this is the first time we tried this, so we'll see, is you're going to take the MedSurg 2 Kaplan integrated test on Monday at 1 o'clock in 1418 on those laptop computers. We'll hope that works out. It's only 75 questions on the MedSurg integrated test, so we'll give you plenty of time for that. That means between the time you take the integrated test on Monday and Thursday at noon, when we post your course grades, we need to have you have that length of time to do your remediation. Fortunately, it's only 75 questions. Most of you will want to try to remediate every question for 2 minutes. So we don't know what you're doing while you're remediating. If it's a question you got right and you know it, you could comb your hair, or I don't know what, sitting at your computer. Look on Facebook, on your cell phone, I don't know. But the whole point of this remediation thing is to get you to do it. It's to try to incentivize you looking back at your capitals and taking these integrated tests seriously and make them work for you. The reason I push not to have the Kaplan, at least for this course, count toward the course grade anyway, is that some of those, it's a standardized national test, and it's not built off of 2020. So you'll see some questions on that integrated test next Monday that you haven't had. And maybe a cardiac rhythm question or something. Do your best so you get your best information about your own strengths and weaknesses. Okay? So we're going to have to go pull the Kaplan report, decide how many points you get. You don't have to remediate. That's an option. That would be 0 points. If you're in the 50th percentile or above, you'll get 3 points. If you are above the 50th percentile, not 50 points, 50th percentile, which we've found is somewhere up in the 70s and 80s probably, scores. And you remediate your right and wrong answers, you get 3 points. And we had some people in 2032 who were in that 50th percentile. If you're below the 50th percentile, you can still get 2 points by remediating all of the questions. If you only have time to remediate your wrong questions, you get 1 point. If you don't remediate at all, you get 0 points. So we're going to try to give you points for this, which can only be a positive. It can't be a negative. The worst you can do is get 0 points or not remediate. So it doesn't count against your course grade. It can only count towards. Okay? Now, 100 questions. I can tell you that 40 questions, I think it's almost exactly 40 questions, will be coming from this competency 12, because you haven't been tested on it yet. The other 60 questions will come from competencies 1 through 11. in kind of even, kind of evenly spread out across the 1 through 11. You've already had the competency 10 and 11 test, so there are a couple of questions from that, but not a lot. So the oncology competency 12 information is 40 questions. Okay, so the drugs we're going to talk about, the nursing management of the patient receiving cancer chemotherapy, and the radiation therapy information is 40 questions of the test next Wednesday. So I find that that's fresh in your mind, and people do pretty well. You've heard these meds before. We're going to do it again. So it'll be fresh in your mind, the information in your study guide. The rest of this appendix is competency 12. There are several handouts. Now, this chart that we talked about last week is from your study guide. Everything you really need to know, other than the nursing management, which is important, about the chemotherapy drugs is on this chart. Because we walked through, and I'll do it again quickly, the category, the common drugs, and the common side effects of those categories of chemo drugs. You also did drug cards in lab, you did a chemotherapy crossword puzzle, you hung adriamycin, et cetera, saw a patient getting shock combination chemo for non-Hodgkin's lymphoma in that lab exercise. Okay. And then we'll also talk this morning about radiation therapy, so I don't want to take too long getting going here. All right. But my point about competencies 1 through 11 is you do need to go back, and that's kind of the hardest thing because you're remembering what feels like ancient history at this point. I mean, remember we had snow, that was all this semester. But you were tested on all the other competencies. So go back and look at neuro. There may be 1, maybe 2 questions on spinal cord. So of course you need to know what autonomic dysreflexia is, right? You need to remember a little bit about those degenerative neuro disorders. I advise you to go restudy myasthenia gravis. So you know what myasthenic and cholinergic crises are. Okay, what you do give tensilon for. Remember all that? Way back. Competency 3. Look at your renal failure or your liver failure competencies again. The concepts that are important from those competencies. Go back and look at endocrine. If you didn't do well on test 3, make sure you fully understand diabetes, but also thyroid, hypo and hyperthyroid, hyper and hyperadrenal. The pituitary gland, what does it do? What happens when you remove it? Diabetes insipidus, for example. Go then look at competency 9 again. The joint replacement information. There's only going to be a couple questions from those things, but hey, you still want to do that. You still want to do well. Okay? All right, so let's go back now and talk about competency 12. Nursing management of clients or patients receiving anti-neoplastic drug treatment. So that means drugs given to kill cancer cells, right? What is cancer chemotherapy? Now, I actually tried to buy, the DVD that comes from this book, The Emperor of All Maladies, Pulitzer Prize winning book that came out recently. I did buy the DVD. They mailed it out on Monday. I'll probably go home and it'll be in my mailbox today. Which is too bad, because there are a couple things I wanted to do. It's a wonderful Ken Burns 6-hour PBS special on the history of cancer and cancer treatment. But it was taken from this book. So to start us off talking about chemotherapy, and I know I'm dating myself, but from part of this book, I just want to read a few paragraphs to start us out. This chapter is called The Smiling Oncologist. Every battle needs its iconic battleground, and if one physical place epitomized the cancer wars of the late 1970s, it was the chemotherapy war. It was our trenches and our bunker, a chemotherapist, meaning oncologist, recalls, a space marked indelibly in the history of cancer. The Oncology Nursing Society began in 1975. They're celebrating their 40th anniversary, and right now they're doing their national convention in Orlando. went from about 500 of us in 1975 to like 20,000 members now. And oncology nursing is a large nursing specialty with its own group, its own certification, its own education standards. In 1976, a novel drug, cisplatin, appeared in the cancer wards. Cisplatin, short for cisplatinum, was a new drug forged out of an old one. Its molecular structure, a central plantar platinum atom with 4 arms extending outward, had been described back in the 1890s. But chemists had never found an application for cisplatin. The beautiful, satisfying, symmetric chemical structure had no obvious human use. Like all cells, bacteria need to replicate DNA in order to divide. Cisplatin had chemically attacked DNA with its reactive molecular arms, cross-linking and damaging the molecule irreparably, forcing cells to arrest their division. Let's skip 5 pages here. Cisplatin was touted as the epic chemotherapeutic product of the late 1970s, the quintessential example of how curing cancer involved pushing patients nearly to the brink of death. By 1978, cisplatin-based chemotherapy was the new vogue in cancer pharmacology. Every conceivable combination was being tested on thousands of patients across America. The lemon yellow chemical dripping through intravenous lines was as ubiquitous in the cancer wards as the patients clutching their nausea basins afterward. The NCI, National Cancer Institute, was formed in 1971 by Richard Nixon as the War on Cancer. Meanwhile, was turning into a factory of toxins. The influx of money from the National Cancer Act had potently stimulated the institution's drug discovery program, which had grown into an even more gargantuan effort and was testing hundreds of thousands of chemicals each year to discover new cytotoxic drugs. The strategy of discovery was empirical, throwing chemicals at cancer cells in test tubes to identify cancer killers, but by now, unabashedly and defiantly so. The biology of cancer was still poorly understood, but the notion that even relatively indiscriminate cytotoxic agents, discovered largely by accident, would cure cancer had captivated oncology. We want and need to seek better guidance and are gaining it, the head of NCI admitted in 1971. But we cannot afford to sit and wait for the promise of tomorrow, as long as stepwise progress can be made with tools at hand today. The seductive phrase, magic bullets, had seemingly been foreshortened. What this war needed was simply bullets, whether magical or not, to annihilate cancer. Chemicals came pouring out of NCI's cauldrons, each one with a unique personality. There was Taxol, 1 gram purified from the bark of 100 Pacific yew trees, whose molecular structure resembled a winged insect. Adriamycin, discovered in 1969, was blood red. It was the chemical responsible for the orange-red tinge. Even at therapeutic doses, it could irreversibly damage the heart. Etoposide came from the fruit of the poisonous mayapple. Bleomycin, which could scar lungs without warning, was an antibiotic derived from a mold. Did we believe we were going to cure cancer with these chemicals? George Canellos recalled. Absolutely, we did. The NCI was a charged place. The chief wanted the boys to move into solid tumors. I proposed ovarian cancer. Others proposed breast cancer. We wanted to get started on the larger clinical problems. We spoke of curing cancer as if it was almost a given. In the mid-1970s, high-dose combination chemotherapy scored another sentinel victory. Burkitt's lymphoma, the tumor originally discovered in Eastern Africa, was cured with a cocktail of 7 drugs, including a molecular cousin of nitrogen mustard. The felling of yet another aggressive tumor by combination chemotherapy even more potently boosted the Institute's confidence, once again underscoring the likelihood that the generic solution to cancer had been found. There is no cancer that is not potentially curable, an ovarian cancer chemotherapist self-assuredly told the media at a conference in 1979. The chances in some cases are infinitesimal, but the potential is still there. This is about all that patients need to know, and it is about all that patients want to know. Okay, that's just a small couple of paragraphs out of this. out of this book. And in the show, in the movie, in the documentary, it does show people throughout history, starting prior to this, with Sidney Farber at the Sidney Farber Cancer Center, it's called now, in Boston, who first was able to get remission for children with acute lymphocytic leukemia using combination chemotherapy. And he started his work 10 years before all of this, 10 years before the National Cancer Institute was started. So that's what I was doing in the 70s. We were literally giving combinations of drugs to people to see if it helped. First of all, in phase 1, to see what the toxicities were. Then see if it actually shrunk the tumor or not. And then what combinations got the best survival curves. And so the ASCO conventions at the time, the American Society of Clinical Oncologists, would put up survival curves and say, well, this combination, the average lifespan is 3 months longer, literally, or 6 months longer than this combination. And that's where the chemotherapy idea really took root. And so now we've come a long way, and the thinking now, of course, is now that we know the biology of cancer so much more, now that we have the human genome mapped, and we're finding genetic mutations in different cancers, and we're able to target the treatment to the genetic mutation of that person's cancer, because we know breast cancer is like 4 different diseases. So we don't want to give everybody the same treatment. That's what we were hoping would work in the 70s. Did it work? Well, for some cancers it did. For the highly chemosensitive tumors like leukemias and lymphomas it did. But we didn't make a lot of progress in some of the solid tumors with cancer chemotherapy. We're still using it, but it's less commonly used now, or it's used in conjunction with the targeted therapies and some of these new novel radiation therapy treatments. Okay? So I wanted to give you a little bit of historical perspective when it says, what is cancer chemotherapy? Because you do still need to know these drugs, and we are still using them, especially if somebody has a chemosensitive cancer like a lymphoma or a leukemia. So in some cases, the goals of cancer chemotherapy are still to cure. So if you have Hodgkin's disease, even stage 4, Hodgkin's lymphoma, or you have ALL, or a child does, or you have Burkitt's lymphoma, or the other thing that was in that chapter, testicular cancer, they are curable by the use of cancer chemotherapy, combination cancer chemotherapy. We also use adjuvant chemotherapy. And adjuvant chemotherapy is used to eradicate any possible micrometastases that may be remaining after the primary treatment. So other studies that we did, one was called the National Adjuvant Breast and Bowel Project, and it randomized women with breast cancer to 2 groups. When you do a double-blind randomized study, one group gets the treatment and one group doesn't. And one group, after their mastectomy, received adjuvant combination chemotherapy just to try to see if it prevented recurrence. Even though the surgery got it all, quote unquote, they're thinking there might be some micromets floating around in sanctuaries where they're not being found. And the systemic chemotherapy was trying to eradicate or kill those. And the study showed that it did. So now it's very typical to have a patient after surgery receive adjuvant radiation therapy and adjuvant chemotherapy to eradicate or kill any of those micrometastases that could lead to a recurrence. Breast cancer can be a sneaky disease. It can come back 10, 20 years later. So the adjuvant chemo is used for a lot of cancers now. For breast, for colon. After the primary treatment is finished, they'll still give adjuvant chemotherapy to prevent recurrence. In most cancers, cancer chemotherapy drugs are given to control the disease. In other words, to extend the quantity and hopefully quality of life that that person has. And sometimes for years it can control the disease progression. They may have, say, stable disease, not a cure, but the chemo may keep it from getting bigger or spreading. So in most cancers, we use it for that. For the non-Hodgkin's lymphomas, the non-lymphocytic leukemias, lots and lots of other diseases, a lot of the lung cancers, like OAT cell or small cell CA of the lung, they'll use it to control the disease. And you can give people more time. even with stage 4 colon cancer that's spread to the liver and other organs. They can use these combination chemo protocols to keep people alive. They may get an extra good year or two with stage 4 colon cancer. And so most people will choose to take these treatments if it's that kind of those kind of odds. Of course, it's not, we know now that it's not a magic bullet, and so it works well in some cancers and not so well in others. Palliation is another legitimate use for cancer chemotherapy, where it's given to keep people comfortable. Palliative means just that, doesn't it? So if you have a tumor that's pressing on, vital structures, obstructing the bowel, causing a lot of pain, and you want to shrink it with this modality, that might be another use for chemotherapy. Not curative, but palliative. All right, we went through these drugs last week. You probably heard my voice. Here it is again. On that page that has that chart, the best use of your study will be to take this chart, circle the drugs that you're going to be tested on, which were the drugs we did, the drug card and the crossword puzzle, and then study from this. I like the way it's all on one page. The categories of chemo drugs, right? These are anti-neoplastic agents used to kill cancer cells. You don't need to know the mechanism of action, but since they're all cell poisons, except for the hormones, they're going to be cytotoxic in some way at some part of the cell cycle. Now, cancer cells and normal cells all go through the same cell cycle. But some anti-neoplastic drugs are cell cycle non-specific, like the alkylating agents and their subtype, the nitrosoureas, like the anti-tumor antibiotics. But some chemo drugs only kill the cell at a certain part of the cell cycle. For example, the antimetabolites only kill the cell during the S phase of the cell cycle, where synthesis of DNA and RNA takes place. And the antimetabolites defraud the cell of normal metabolites, or nucleic acids, and it dies because it can't synthesize DNA and RNA. Is that a test question? No. You're not pharmacologists. But the plant alkaloids are mitotic spindle dissolvers. So they work during the M phase or metaphase, where the cell is dividing into two daughter cells, and if it dissolves the mitotic spindle, it kills them both. Okay? So that's what those two columns are, the mechanism of action and the cell cycle specificity. What you need to know is the particular drugs that we're going to go through real fast here, because you've had it before, and then the common side effects and the nursing management, okay, of the patients getting these drugs. Who gives chemo? RNs. Doctors really don't do it. I mean, many years ago, they may have done some of it. But even when I worked for NCI, the nurses were giving the meds. The pharmacies will make it. Nurses don't make it at the bedside anymore, thank God. We wear protective OSHA equipment to protect us from the toxicity, people who are mixing and giving the drugs. But the nurses are giving it, the nurses are supporting the patients, as we always have. The nurses are doing the patient education, etc. Okay. So remember, nitrogen mustard was the first chemo drug, actually used in the 40s for kids with ALL, because they found that soldiers who were exposed to mustard gas in World War I came back leukopenic. In other words, it suppressed their white counts. So they said, these leukemia kids have these really high white counts. Now, they were lymphoblasts, not lymphocytes. So they were baby, immature, non-functioning white cells, but their white counts were very high. And so they tried it. Well, it's very toxic, but it is the mustargin MOP, which worked to cure Hodgkin's disease, the first cancer cured by combination chemotherapy. And it's a vesicant agent. So if you're giving mustargin, Cytoxan, adriamycin, vincristine, it's very important that you prevent what? Extravasation. Extravasation of a vesicant could cause tissue death. Makes sense, these are cell poisons. There are other drugs that are vesicants besides chemo drugs. We think it's always chemo. It's not always chemo. Levophed, dopamine, those things are vesicants too.
Aren't all chemo drugs
No,
vesicants?
they're actually not. It's kind of interesting. It's kind of like some are worse than others, because we have a category called irritants. So the worst drugs to extravasate or infiltrate tray are called vesicants. And there's actually protocols, antidotes, all of that for management of vesicant extravasations. Other chemo drugs that are a little less toxic are called irritants. And there are other irritants that we have outside of the chemo drugs. So the big ones are actually called vesicants, and the ones that are just plain old irritating are called irritants. That's a good question. Okay, cytoxin, cyclophosphamide. The drug-specific side effect we talked about for that was hemorrhagic cystitis, bleeding from the bladder. That's why you give it in the morning. You don't want to give it at night, having it sit in the bladder and act on the bladder wall during the night. What else do we teach people that are getting cytoxin related to that? Drink a lot of water. Good. Flush it through, pee it out. I just mentioned the discovery of platinol, or cisplatinum. Interesting drug, found that it worked a lot in, and it also, I didn't read you the patient's scenarios, it would have made it too long, but guys that were being cured with advanced testicular cancer, patients who had always died now were getting cures from these platinol-based chemotherapy protocols. They still use it a lot. Cisplatin, carboplatin, oxaliplatin. These are for lung cancers, colon cancers, etc. It is nephrotoxic, so that's the drug that you want to pre-medicate them with what? Mannitol and saline. You want a nice IV bolus, say 500 mils, maybe even 1,000 mils of saline, and add some mannitol, which of course is an osmotic diuretic, increases renal perfusion by increasing the vascular volume. Okay? And highly emetogenic. It goes through this talking about the nurses calling it cisplatin. When we gave these drugs and they worked, we also had to manage the side effects. And so when you see some of these old movies and they show people practically dying from dehydration from the vomiting, that was because we didn't have good antiemetic therapies. It wasn't until the 90s that what was developed? What do you think it was? Zofran, Dancitron, yeah. Zofran, Anzamet, Kytril, Aloxi. They were very expensive. They're still pretty expensive. But Zofran was a huge advancement in managing CINV, chemotherapy-induced nausea and vomiting. Okay. So with a highly emetogenic drug like platinol, they have to have good pre-medication with Zofran and other drugs that are actually added to the anti-emesis protocol. They get Zofran, maybe some Decadron, some Reglan, Ativan. They may do a couple of things in a cocktail. And then they should still take that Zofran every 4 to 6 hours, sometimes for up to 3 days, following the administration of a highly emetogenic drug like platinum. Okay, now the common side effects, if you look along that right column of the chart, it says bone marrow suppression. So we're going to talk about that. Myelosuppression, nausea, vomiting, alopecia, and then it has some of the specific ones for the drugs. Those are what we call the typical side effects. So the nursing management of those typical side effects is critical. So the point, the concept, which I know I've said before, but I'll say it again, the side effect profile of cancer chemo drugs, these cytotoxic drugs, is that we want to give them, we're fighting fire with fire here, we want to give them to kill rapidly divided cancer cells. The side effect profile is most serious in the rapidly dividing normal cells. So you're giving it systemically, IV, through a central line, and it's going everywhere. And you want it to get to the cancer cells. But in the meantime, it's also going to be toxic to the rapidly dividing normal cells. So that's where you get into the myelosuppression, the rapidly dividing normal cells in the bone marrow, the gastrointestinal mucosa, the GI mucosal cells from your mouth to your anus turn over every day and a half. Those are rapidly dividing normal cells. So think mouth, esophagus, stomach, intestines, rectum. That's the GI side effects. Your hair follicles, your hair is rapidly dividing. So in some of these really potent classifications of chemo drugs, there's alopecia. Now that might not be clinically significant to as they call them, the smiling oncologist, but it's important to the patients, isn't it? Okay. So these drugs are very myelosuppressive, the alkylating agents, which means they're very effective. They also are very toxic. Nitrosoureas is a subtype. There's no questions from that. If you see a drug like CCNU, BCNU, methyl CCNU, those are called nitrosoureas. They are alkylating agents. They cross the blood-brain barrier, but the bad news is the neurotumors, the adult ones, tend not to be very chemosensitive. We use other things for that. Okay, the antimetabolites, the ones I said, are S-phase specific. The drugs that we talked about were Ara-C, cytosine arabidoside, or Cytosar, which is the part of the induction chemotherapy protocol for AML, non-lymphocytic leukemia, myelogenous leukemia. They give it to induce remission. You have induction therapy for these leukemias, then you have consolidation, and then you have maintenance. You do want to give maintenance drugs to maintain the remission once somebody achieves it. Does everybody get a remission? No. But if they do, you want to maintain it. 5-FU-fluorouracil. Again, remember we mentioned that these drugs in this category are very active in the GI tract. So what kind of cancers would you expect to see 5-FU given for? Colon cancer, colorectal cancer, stomach cancer, esophageal cancer. Okay, good. And methotrexate is another one. You actually see methotrexate given orally in a very small dose in rheumatology. They use it for rheumatoid arthritis and some of those autoimmune connective tissue diseases. But it's a chemo drug, it's an antimetabolite. So the toxicities of this category are related to what body system? GI. GI toxicities, the gastrointestinal mucosa. So what is stomatitis? It's inflammation of the oral cavity, the stoma that you eat through, right? Your mouth. Nausea and vomiting, that's GI. Diarrhea, proctitis is inflammation of the rectal area. Okay? So that's important for patients to know and know how to manage. And then it's mildly myelosuppressive, not as much. You know, I don't have a whiteboard here. Let me mention, well, we'll talk about it when we get to myelosuppression. Let's just go through the drugs real quick here, because we've done this already. The anti-tumor antibiotics, they are antibiotics. They're antibacterial. But they also kill certain types of cancer cells. Bleomycin, which is mentioned in what I read to you, can cause pulmonary fibrosis, which means we need to know the patient's pulmonary function prior to giving it. So what's the test that looks at pulmonary function? The pulmonary function test. Good. So you don't make it hard. PFTs. And you know what that looks at. It's like what's that thing you blow into for asthma? Peak flow meter. Yeah, it's looking at forced expiratory volume. Blow it out, blow it out, blow it out, blow it out, blow it out. I've had PFTs before. They're looking at the ability to breathe out, which can be affected in COPD patients. Okay, so you don't give bleomycin to somebody who doesn't have good pulmonary function, because it does cause scarring, also known as fibrosis. Leo can also be highly likely to cause an allergy. That's why it says anaphylaxis. So if we're giving a drug with a high potential for anaphylaxis, what do we want to do before we give it? Give a test dose. Right. Okay. Now, the daunorubicin and doxorubicin, which I mentioned here, adriamycin, there was actually a drug company that got rich just making adriamycin. The Ruby, yeah, a lot of drug companies got really rich doing a lot of this stuff. The thousands of drugs that were churned out in the 70s, 80s, and 90s. Most of them were analogs of the original drugs. They were trying to make them less toxic. In some cases, they did. So Ruby means red. That's the Latin root there. And they're very effective. So if you see an A in a combination chemo protocol, it's likely to be adriamycin. We still use it. But these drugs are very toxic. The common side effects is what they say here. Just like the alkylating agents, the anti-tumor antibiotics are also highly myelosuppressive. So if somebody's got severe myelosuppression, what happens to their counts, their CBC? Everything drops. What do we call that? Pancytopenia, all cells low. Good. Okay, so they're very myelosuppressive, they're very metagenic, and if somebody's getting one of these drugs, their hair will fall out. You'll hear patients say, oh, well, I took chemo, my hair didn't fall out. Well, you're not special, it just depends on what drug you got. It's not you have stronger hair. Okay. And then the cardiotoxicity. So we talked about that, I know. It's very important when you're giving a cardiotoxic drug to know first what their heart function is, right? Because the drug can cause cardiomyopathy. It can actually kill myocardial cells. So what tests do we want to know before we give a cardiotoxic drug like Adrian? An echo, thank you, an echocardiogram. They have a MUGA scan that gets some of the same data, but the good echoes now, you can do transesophageal echoes and all the 3D echoes, looks at left ventricular ejection fraction, which is how well does the left ventricle pump the blood out, which affects cardiac output. So if somebody gets a cardiotoxic drug, gets cardiomyopathy, they can go into heart failure. So what signs and symptoms would we teach the patient to report? If you have right-sided heart failure, what are the signs and symptoms? Weight gain, dependent edema, hepatomegaly, JVD. If you have left-sided heart failure, your shortness of breath, you can develop what? Pulmonary edema. Good, which is really a cardiac problem, isn't it? Pulmonary edema. It's from heart failure. And the wet lung sounds. If they've got rails halfway up their bases and they're short of breath, something's not pumping well on the left side of their heart, probably. Okay? I even mentioned this in the voiceover. I still remember, because there's actually a wing of University of Maryland Hospital with her name on a plaque. Since her name's on the plaque. Vicki Dotson was our patient. She was a young woman with AML, married, small children, late 20s. She, the only drug that was putting her back into remission for her AML, acute myelogenous leukemia, after she was relapsing, was adriamycin. So she made a conscious decision with her oncologist to go above what we call the cumulative lifetime dose, which you don't need to know, but it's 550 milligrams per meter squared. Because how do we dose chemo? We dose it on body surface area, right? So it's dosed on milligrams per meter squared, and her BSA, which is based on her height and weight. She went above the cumulative lifetime dose. We have that for radiation therapy too. Above a certain dose, they're not going to give you anymore. But it was working. So she, and the other second line, third line drugs weren't. So the sad end of this story, lovely like young woman and family, was she did get the adria, she did go above consciously understanding the risk, and she died of cardiomyopathy and heart failure. We're just starting to use Langerhans catheters then for hemodynamic monitoring. She died of heart failure, going into bone marrow remission. So it was working for her leukemia, but she died of the heart toxicity. And those things you remember when you have an example like that from an experience. Okay. The plant alkaloids came from natural products. I mentioned in that what I read to you about Taxol coming from the yew tree in Oregon, and etoposide from the poisonous mayapple, and vincristine and vinblastine from the vinca plant, little periwinkle plant. And we have a lot of drugs that we use today, made synthetically by big pharma, by pharmacology companies or drug companies, and they were originally plants. There's a whole branch of, if you study pharmacy, called pharmacognosy, which is the study of natural products. Many of you come from countries where they still use herbs. The Chinese herbs have been used for thousands of years. If you did mass spectroscopy on some of those, you would find out that they were digoxin, or they were, some other drug that we use today, that we give internationally, synthetically, based on the generic name. Okay? Anyway, the V drugs, vincristine, vinblastine, vincristine, and VP16 are natural products called plant alkaloids. Oncovin is the brand name for vincristine. So if you see oncovin, or an O, like in CHOP, or the MOP, CHOP, the ALL protocols for the kids with acute lymphocytic leukemia, it's usually oncovin. Still works very effectively. Now, the drug-specific side effect to this category that's different is what? Neurotoxicity, peripheral neuropathy, paresthesias, which is numbness and tingling, weakness in the arms and legs. We had a young guy with ALL. He was in his 20s by the time we had him at the cancer center, and he was cured of his ALL, but he was paraplegic from too much vincristine, and he got really bad peripheral neuropathy, and his legs got too weak to walk. He probably should have not gotten that much or been more carefully monitored. And then there's a neurogenic constipation. Most of the other drugs cause diarrhea, but the constipation is to slow down, almost like a neurogenic battle, in the toxicity from the plant alkaloids. I also mentioned the taxanes, from which Taxol is derived. That would be another category of plant alkaloids. Again, not on your test. Okay. So you've circled those drugs as we went through on that chart. Last category I'm going to mention is the hormones. Now, the hormones are not cytotoxic drugs. They're not cell poisons, but they change the hormonal environment of the body to make it less favorable for tumors to grow. The first one here, interestingly, is the corticosteroids. Remember I talked about corticosteroids actually causing lysis of lymphoid tumors. So in lymphomas and lymphocytic leukemias, this is actually a chemo drug, high-dose prednisone. You saw that in the CHOP protocol, where we hung the adriamycin. They were giving high-dose 100 milligrams of prednisone Q-day times 5 days. You'll see the little moody-faced kids with ALL. That's from all the prednisone. So that only works as a chemo drug in lymphoid tumors. Otherwise, it's not part of the chemo protocol. It is still a corticosteroid, and corticosteroids normally are given because they are powerful what? Anti-inflammatories and immunosuppressives. You may give it for one or both of those purposes. Now, the reproductive hormones are given for reproductive cancers. I know we talked a lot about tamoxifen, which is a synthetic anti-estrogen used in the treatment of estrogen receptor-positive breast cancer. And there's other drugs similar to that, the aromatase inhibitors or some newer drugs that do that. And then the anti-androgens and anti-testosterones, drugs like Lupron, Casodex, take away the male hormones in patients with prostate cancer. Okay? So the side effects would be, as you would expect, in a woman taking tamoxifen, taking away her estrogen, she's going to get these sort of masculizing effects, and the hot flashes and the vaginal dryness. And in the men, taking the anti-androgens and anti-testosterones, you would think the side effects would look like what? What we call feminizing side effects, gynecomastia, loss of libido, etc. Okay. All right. And miscellaneous agents are ones that don't fit into any other category. So you have some there at the bottom. We don't need to talk about that. So most of these drugs, especially if they're vesicants or irritants, are given by what route? IV. Through a large vessel, which is why now the oncologist sends the patient to a surgeon to get a portacath or a Rochon or some kind of long-term venous access device placed prior to starting their chemo. Some drugs are given orally. Prednisone is an example. The new targeted therapies, some of those are actually given orally because they're not cell poisons. They're actually given orally. There are some oral versions of chemo drugs. There's a drug called Xeloda, which my father got for colon cancer. It's a prodrug with 5-FU. You can take it orally, capecitabine. It goes and becomes 5-FU in the body. So there are some oral drugs given as chemo drugs, and especially more now with the targeted therapies, the monoclonal antibodies, the tyrosine kinase inhibitors, some of those other immunotherapies. And the big push now is immunotherapy. Saw something on the news just the other night. Oh, we have a whole new cancer curative treatment. I've heard thousands of those in 40 years. This one is related to monoclonal antibodies, changing the immune system to help patients with melanoma. There's a lot of immunotherapy protocols for malignant melanoma because it doesn't respond much to anything else. Okay. Sub-Q, we still give something sub-Q, especially the colony-stimulating factors, like Neupogen and Epogen. Intracavitary, there's a whole group at Washington Hospital Center, Dr. Sugarbaker's group. They bring patients from all over the world who have intra-abdominal metastases, ovarian cancers, etc. And he does these 8, 9, 10-hour debulking procedures in the OR, gets as much as he can. Then they give intraperitoneal chemo, dwell it, almost like peritoneal dialysate. It's chemo. Switch them side to side and drain it out. And they go on a particular unit at hospital center. Intrathecal chemotherapy is given into the central nervous system. If a child has CNS involvement with his or her ALL, they're going to give intrathecal or IT methotrexate. So how would you get something into the CNS? Usually it's an LP, it's a lumbar puncture or spinal tap. They'll do an LP, pull off a certain number of mLs of CSF, depending on the size of the person, cerebrospinal fluid, replace it with the equal volume of, in this case, methotrexate, and it circulates up through the CSF into the brain, into these CNS sanctuaries that some of these cancers can develop, like ALL. Okay, so intrathecal. They also have these fancy, if you work in pediatric neuro-oncology, very subspecialized, they have these little things called Ommaya reservoirs. And they actually put it under the scalp and run the catheter into the ventricle of the brain. And then they can access that almost like a portacath, but it's intrathecal route for medications into the brain. Okay. So, we've done this. Here's a portacath, which of course is subcutaneous. It's a central line. It's accessed with a non-coring 90-degree Huber point needle. You all understand how it's accessed, flushed, managed. They can go for 2000 sticks unless they get, what? Occluded or infected and they can't fix it. The occluded, sometimes now they can do cath flow, which is TPA, tissue plasminogen activator, which is a thrombolytic agent, and they can get it going again. But if it gets hopelessly clogged or it gets infected, they'll have to disimplant or take it out, and the doctor would do that. The Groshong, Hickman, Broviac, all examples of the tunnel catheters. You still see those a lot in pediatrics. Again, it's a good way to give multiple sticks. You just hook up the patient and they have central line venous access. PICC lines are peripherally inserted central catheters. So they do send a lot of people home now with PICC lines too. Less likely for chemo, but you can use it for chemo because it's a central line. All right. The OSHA Safe Handling Guidelines. There's some information in your study guide in the appendix. You don't need to memorize that. We're really not getting into that level. This isn't an ONS chemo certification course. But, again, dating myself, we used to mix these drugs up at the bedside, squirt them up in the air, mop them up with a paper towel. Nobody wore gloves. The only people who had gloves were the OR. We were not. We were at the bedside. And then we discovered that, interesting thing, and I remember this. Some of the nurses that worked all day with chemo in the outpatient clinic, where they give most chemo and always have, were having problems with miscarriages. We thought, this is interesting. So, talked to the baby, the new group called the ONS, Oncology Nursing Society, and they did a study of urine of chemo nurses. And they found mutagenic activity in the urine of nurses that handled a lot of chemo all day long. Well, kind of a duh. Guess what these cell poisons are poisonous to? The people who are mixing it and giving it to. We're giving it to patients. Hopefully they're giving you informed consent and understanding the risks and benefits. But the nurses were also being exposed to it, especially if we were squirting it up in the air. That's aerosolization and bringing it into inhaling it. So after they did the study, the Occupational Safety and Health Administration, which is a national organization, and then there's the local ones like MOSH, which is from Maryland, developed these safe handling guidelines. So now when you give chemo, there's a kit, and you put on special blue nitrile gloves, a gown with a cuff that covers before the end of the gloves. You wear eye protection. Unless people are getting a little sloppy, which unfortunately, does happen at some of these places. These guidelines are meant to protect people who are giving the drugs, who are the registered nurses. Okay? That's a good thing. Management of extravasation, again, there are protocols, don't worry about it. There's a little money-in handout that's nice to look at. Talks about, what would you, first thing you would do as a nurse if you're giving, say, an IV push adriamycin, and you suspect that it's infiltrating or extravasating. What's the first thing you would do? Stop giving it. Right, shut it off. Then, would you take the catheter out? Well, that was peripheral. I can't kick it out, it's central. The next thing you're going to do is you're going to take an empty syringe and aspirate and pull back and try to get anything that's left in the line, or maybe something at the end of the catheter, pull it back to get whatever's in there out. And then there are other things they could do. They can elevate the arm, put ice, unless it's certain drugs, you put heat. Then there are antidotes. People can put the area around with sub-Q, steroids, etc. Okay, so we're not testing you on management of extravasation. But they should have an extravasation tray and extravasation protocols with standing orders for managing this if it happens. Okay, now, patient supporting teaching. This is the most important part of this. Because you are giving the meds to the patients, It's their disease, it's their informed consent. They're the ones that are going to go home because this is mostly given electively as an outpatient. It can be given electively as an inpatient, but these aren't drugs you see given usually in the middle of the night in the emergency department. If they are, the emergency room nurses are not going to touch it, I can tell you that. They'll run for the oncology people. Even in the ICU, where they're getting all these vasoactive drugs, they don't want to, they're like this with chemo drugs. Oh no, I don't do that. Get the oncology nurse. Because they haven't had the training and they're not comfortable with it. Okay, so the next part of your appendix, there is a care plan. And the care plan, the care plan says problem, which means, or pathology, which means the drug side effect. Anybody find the page for me? I have it marked with this. This is a chemotherapy precaution sign. Oh, page 261. Page 261 and 262. It's a really quick, little, easy care plan. It has the side effect, the signs and symptoms, and finally, we're getting to this, the bullets for the nursing interventions, the nursing management piece. Page 261 to 262. The rest of the appendix is all stuff you're supposed to look at, if you haven't already. It's got a little article on chemo side effects, and then a whole bunch of handouts for radiation therapy, which we're also going to do this morning. These, I took off the door at Doctor's Hospital. Anne Arundel Oncology Union has similar kinds of things. This says chemotherapy precautions, so we're going to get to that as we talk about nursing management. This is part of the nursing management, that these are put on the door, that people understand them, that the patients understand them, that the patients can protect themselves, which is kind of what neutropenia precautions is, isn't it? It's what we call reverse isolation or protective isolation. In most isolations, we're protecting us from them. And neutropenic precautions, or reverse isolation, we're protecting them from us, right? So if you walk into that patient's room and they don't see you wash your hands, they can call you on it. And they do. Okay. And they should. Okay, so let's go through this, and we'll get to this as we go. All right. Myelosuppression causes pancytopenia. All cells low. So it's really important to know the patient's CBC because chemotherapy is given in what we call cycles. So say the patient comes in for CMF, cytoxin methotrexate 5-FU, or MOP, or CHOP, or whatever. They have what we call day one. They get their drugs, they go home, if it's an outpatient, which most people get it at the doctor's office, the oncology offices, or the infusion centers in these hospitals and med centers. And then within the next 10 to 14 days, their counts drop to the lowest point in their counts, which we call the nadir, the lowest point in the myelosuppression. It's an expected effect, but it's very potentially dangerous. Myelosuppression is the most potentially clinically significant side effect for giving or not giving chemo. So if you give, say, 3 drugs on day one, we know from research what the nadir is of the myelosuppression for those drugs. So say it's 14 days later. The patient is now pancytopenic, which means they've become anemic, which means in their counts what's low? RBCs and H&H. They become thrombocytopenic, so what is now very low? Their platelets. And they become leukopenic, and particularly neutropenic, which is the most prevalent and most important infection-fighting granulocyte, or white cell. Okay, and then we know that with research that at about day 21, the counts will return to normal, or close to normal. So what do the nurses need to do before they give cycle 2, 21 days later? Check the CBC. What if they haven't had sufficient bone marrow recovery and they're still low? We need to call the doctor, and we need to get an order, because the oncologist will say this, to hold that cycle of chemo. So that's the most clinically significant, because what could happen if you give a myelosuppressed patient another cycle of 3 or 4 chemo drugs? They could die. And what do they die from? Infection or bleeding. Exactly, and that's how chemo can be deadly, infection or bleeding. So the myelosuppression is very clinically significant. That would be a reason to withhold the next cycle of chemo. So then on day 21, if their counts have rebounded, bone marrow recovery, we call it, they'll get another cycle of chemo. 21 days later, they'll come back again, and they'll get another cycle. And some of these protocols will give these cycles of chemo for up to, 5, 6, 7, 8 cycles of chemo. And as long as the patient is tolerating it and it's working, which is the whole point, they'll continue to give these cycles of chemo with these times in between for the myelosuppression to happen and then to resolve, and then to happen and then to resolve. Okay? Okay. So let's talk about anemia. We've done this, I know, in my group. So if the H&H is low, signs and symptoms of anemia, well, what do red cells do? Carry oxygen. So the signs and symptoms are related to that if it's low, which means they're going to have fatigue, pallor, dyspnea on exertion. How do we treat it? Rest, oxygen, possibly epigen if they qualify for that, and blood transfusions. If it's really low, we can give them packed red blood cells, right? And then we want to know their H&H before and after the packed red blood cell transfusions. And if it works well, patients feel a lot better, don't they? Okay. And there's other things we can use, iron, folic acid, those kind of things can help to stimulate red blood cell production. Okay. Thrombocytopenia. What's the normal platelet count? 150,000 to about 300,000 or 400,000. What's the patient at risk for if their platelets are below 20,000? Bleeding. So now they need to be on bleeding precautions, right? All that's entailed in bleeding precautions. Things to avoid trauma, to avoid invasive procedures. Use the soft tooth X, all that kind of stuff. And if it's really low, they can give platelet transfusions. But a patient has to be actively bleeding and the doctor has to justify it. We can give random donor platelets, usually multiple units in one bag, just looks kind of pink, given the same way as blood. Or matched donor platelets through plasmapheresis in medical centers where people are actually matched to the person they're giving their platelets to. And of course then we're hoping it will get up high enough that patients will stop bleeding. And then, as the bone marrow recovers, they'll make their platelets again. So what do we want to monitor for patients who are severely thrombocytopenic? And we want to look at their coagulation times and their platelet count mostly. We're really just looking at platelet count because that's what's a problem. But we're monitoring their urine for hematuria, and we're monitoring their stool for blood, and we're monitoring their mouth. What's the word for a nosebleed? Epistaxis. They can bleed from any orifice. They can also bleed into their brain. So we want to know their level of consciousness. I have seen severely thrombocytopenic patients that have spontaneously bled into their brain, in which case we could basically give them platelet transfusions and hope for the best. Okay. So you want to avoid anything invasive. You want to teach them that. Leukopenia, especially neutropenia, now the patient's, of course, at risk for infection. A neutropenic patient can become septic and die within 24 to 48 hours of their first fever spike. That's why neutropenic fever, also called febrile neutropenia, is a medical emergency. So what's your normal white count? 5 to 10,000 or so, right? Elevated might be infection. I see patients walking around, because this is an outpatient treatment usually, with 100 white cells. Severely neutropenic. They're actually better off if they are walking around outside the hospital, because the hospital is where they get the worst organisms. So we try to keep them away from the people in the hospital. Sometimes they're still in the hospital on neutropenic precautions, which I'm going to ask you about in a second. We had a young patient with ALL. He was in his 20s. At 8 p.m., he started to have a fever. Now, we always take Q4-hour vital signs in patients who are myelosuppressed. Okay, most acute care facilities take vital signs every 4 hours. these patients would need, if they're inpatients, to have Q4-hour vital signs, because things can happen fast. So this patient didn't come into the hospital neutropenic, but he had become neutropenic with his chemo, and he also had leukemia. So those people have problems with the immune system anyway. He was wiped out, he was neutropenic. So at 8 o'clock, his temp was a little bit elevated. So what's a fever? A fever is 1.5 degrees Fahrenheit above baseline. So let's say his normal temp was 98, and now it was 99. So she didn't figure anything much with it. Took it again at midnight. Patient's temp was up a little more. But remember, if they don't have any white cells, they don't really have much to mount an immune response with. So they may not get high fever. So the temp was up to maybe 99.8. So she gave him some Tylenol, told him to drink water, you know, cough and deep breathe. The usual things we do for an immunocompetent patient with a fever. 4 a.m., he was looking a little sick, but she decided not to call the doctor. You know where I'm going with this, right? Gave him more Tylenol, you know, a little tepid water bath, made him comfortable, drink some more fluids. We were sitting in report at 7 a.m., right back past his room, and all of a sudden it was like, code blue 354, code blue 354. And it was him. So in that time, he probably had started to be infected a day or so before, but by the time his temp went up high enough and he got sick enough, he went into septic shock quickly. We coded him, we couldn't get him back, and he died of septic shock. Neutropenic. Neutropenic fever, medical emergency. Okay? I had a student say, I was in the NCLEX and I heard your voice, Mrs. Zane. And the question was, which of these is malpracticed by the nurse? And she said, I knew the answer was, the patient was neutropenic, he had a fever at midnight, and she failed to contact the physician. That's called malpractice. Because a neutropenic fever is an irregular fever. I mean, we have kids get fevers all the time. They're immunocompetent, it's no big deal. Post-op of say, a patient who has surgery. 101 temp. Most common cause of fever in the first 24 hours in any surgical patient is what? Atelectasis, right. Have a coffee, deep breathe, drink some water. Okay. But in this case, a neutropenic fever, or febrile neutropenia, is a medical emergency, and it can be admitting diagnosis through the ER. Patient needs to be admitted, they have to do the fever workup, do blood cultures, empirically start them on multiple broad-spectrum IV antibiotic therapy, etc. Okay, so neutropenia precautions. That's to prevent someone. Can you see what's going on? People coming in. If somebody's on neutropenia precautions, they need to know, and their family needs to know, that they're going to be in a private room, which fortunately now we have a lot of private rooms. But if they weren't in a private room and they became neutropenic, we'd have to take the other person out. Door closed, sign on the door. What's the sign on the door say? Wash hands, vigilant hand washing. It also says what should we bring in there? Well, one of the things you should bring in there is snotty-nosed little kids or people with infections. And that also includes nurses with infections. You laugh. Or at least you better be wearing a mask. Fresh flowers, live plants, raw foods. Because somebody who's immunocompromised, what's normal for us, the bacteria that sit on the outside of the fruit, the apple that we're going to bite into, or the pear or the peach or whatever, or sitting in the dirt in the plant or the flowers, they could become pathogenic to somebody. We had an aspergillus outbreak in an immunocompromised population, and they found out that this aspergillus was dropping from the vents above the patient's beds. It was a fungal infection, and because they were immunocompromised, they were getting fungal sepsis. And we're giving a drug called amphotericin, which you don't need to know about, but we call it amphotericin, cause shaking chills. Okay, so these people have to be very careful. Now, they may be at home, which is the best place for them, but they still need to have good hand washing, avoid crowds, use good hygiene, avoid anybody with an infection. And usually the patients and the families are pretty good about the hand washing, maintaining, really good standard precautions. The problems become the doctors, the nurses, the people in the hospital that are there all the and the patients need to protect themselves from us. So that we have to wash our hands, they have to see us wash our hands. And if we're sick, we shouldn't take care of that patient. And we shouldn't put the MRSA patient in the room next door and take care of both patients, right? Does that ever happen? Yes. Should it never happen? No. Best practices, of course, say that you wouldn't take care of those two patients. One with a resistant infection and one that's immunocompromised. So they actually did research on white blood cell transfusions. Very toxic. Didn't go well. People had terrible allergic reactions, that kind of thing. So we actually don't use white blood cell transfusions, in case that popped into your brain. Even with red blood cells, patients who have a lot of problems with allergic reactions will do what they call leuko-reduced or washed red cells, and they'll take the white cells out of the red cells. Those are for special patients that are getting packed red cells. Yes, of course.
Is auto-inoculation with pathogens a huge problem for these patients?
Not really, not really. As long as they do good technique and stuff, are you talking also about immunizations and stuff? No.
No, I'm thinking like from their own.
Well, we did some studies on that too, and we actually had them doing betadine swabs in their armpits, in the rectal area, etc. We also use these very expensive laminar airflow rooms where we put them in like complete isolation. The data didn't show that that made any real difference, and it was very expensive. So some of these auto-inoculation protocols and some of these special laminar airflow rooms, you know, the boy in the bubble kind of stuff, didn't make a difference in their risk of infection or getting their chances or their amount of people who got infected. But we did a lot of that too in the National Cancer Institute research protocols. It wasn't just chemo, it was other stuff too. Okay, and Neupogen was a big breakthrough. Neupogen does increase the production of white blood cells, neutrophils, in the bone marrow. But I want to make one quick comment, because you don't see the Neupogen and Epogen given as often as you used to. You used to have commercials, you know, lady was out and about and then she wasn't, now she's back because she took Epogen. Huge money-making business, the colony stimulating factors. They came out in the late 80s, early 90s. And Epogen has been huge for renal failure, for chronic kidney disease, and because it's synthetic erythropoietin. But they did a study maybe only 15 years ago or so, and they decided not to be so indiscriminate with the use of Epogen and Neupogen in cancer patients, because they figured possibly it was stimulating the growth of cancer while it was stimulating the growth of red cells or white cells. And that kind of turned out to be true. So now they're really only giving it more in the palliative population, people where they're not going for cure, where it's going to make them feel better. But that was discovered from, you know, empiric studies looking at people. Okay, GI side effects. So what do we do for nausea and vomiting? We talked about that. You know what I'm going to do? I'm going to give you your break now because I'm losing you. Let's do the break. It's 10:15. We'll start at 10:30. I'm going to finish talking about, in just a few minutes, the nursing management. If you look at that handout that you're following on page 261, we've talked about, it says bone marrow suppression, pancytopenia, anemia, fatigue, shortness of breath, provide rest. Then it says leukopenia, lower resistance to infection. We talked about personal hygiene, reverse isolation, leukopenia precautions, and then it talks about thrombocytopenia. So it's very important to understand the myelosuppressive effects. That's where people get into trouble. That's the clinically significant part. The GI we can manage, the alopecia we can manage. So go ahead and take your break now, then we'll quickly finish. I'll show Mr. Armstrong how to click the icon on the computer to go into the radiation therapy. But I think you need your break now. I was going to try to finish chemo, but go ahead and go now. Upstairs is cafeteria, there's bathrooms over here. Come back in 15 minutes.
Thank you. You're welcome.
I was the educator, one of the educators, in nursing education at Greater Southeast Community Hospital. Beautiful United Medical Center for 7 years. And so we started the chemo certification course for all the oncology nurses. And we taught them about the OSHA guidelines and safe handling. And we said, if you have, if you have a spill, we have to call the hazmat team, which for the 7 years I was there that we gave a lot of chemo was always the nursing staff, because environmental services really didn't have the training or interest. And the other funny story was, when you are finished with the chemo equipment, the tubing, the bags, anything you use, it has to go in a special hard plastic bucket with a sealed lid. It's a white, ours were the white plastic buckets we got from the manufacturer, and they had yellow caution signs on them, and they had a tight lid. And so we taught the nurses that those buckets would then be sent to a special place for high temperature incineration. That was that part of the process. So, okay, so fast forward a couple of years, and they're going to build a radiation therapy department on the back of the hospital. And in the parking lot that we all parked in, there was a little shed in the parking lot. So we walked by that little shed every day. So they had to tear down the little shed to build on this radiation therapy wing of the hospital. And guess what they found? Piled up to the ceiling, filling the shed, the white chemo buckets. They had been putting them there for a number of years because either they didn't know where to send them or it was going to cost too much money because it was expensive to truck them to West Virginia to the special biohazard high incineration place. So instead of getting them to that place, having a process for that or spending the money for that, they stuck them all out in the shed. So the shed had like 100 chemo buckets in there when they finally tore it down. That's not the process. But, when you think about these things and you institute a new service line, you have to think of the whole process. The nurses are an important part of the process because they're giving the med and teaching the patients. But you also have to have the pharmacy part, what to do for the spills, and where to put the chemo buckets. So, I'm sure a couple of heads rolled, but that's what they were doing. Okay, so GI. We talked about myelosuppression, anemia, leukopenia, neutropenia, and thrombocytopenia. We did say that a very common chemo side effect would be nausea and vomiting. What category of meds is highly emetogenic? Well, the alkylating agents, the anti-tumor antibiotics. What category of drug is active in the GI tract and causes a lot of GI toxicities? The anti-metabolites, like 5-FU. Good. So we talked about anti-emesis protocols. Good. You have to give Zofran, add in whatever else they give adjunctively with that, Decadron, Ativan, whatever, if you're going to give chemo. So it's very important. They have to have that pre-chemo, and they often have to then take it for several days post-treatment. We used to have what they called, I forgot the name of it. And anticipatory nausea and vomiting. Patients would get off the elevator and they'd already be throwing up. Because of the sort of like a PTSD thing. They had such a bad experience that they're already nauseated thinking about it. It's not as bad anymore, but it is still a possibility. People who've had a lot of vomiting. And of course, if they do have a lot of vomiting, they can get dehydrated, and they can have bad electrolyte imbalances, etc. Stomatitis, mucositis of the oral cavity. So we want people to look at their mouth. We want them to have good dental checkups. We want them to keep their mouths clean. We want to use the soft toothbrush. And we also want them to make up a mouthwash. What's the mouthwash they should use made from?
Baking soda.
Baking soda and salt water. Baking soda and saline, which is salt water. And they should use that to rinse their mouth. They also use it for mild stomatitis, but it's preventative and also for treatment of mild stomatitis. What does the baking soda do? Neutralizes the acid in the mouth, and then the salt water is slightly bacteriostatic. Okay? Now, if they get severe stomatitis, and the nurses are doing good oral assessment, etc., there's a treatment that they can get made up in the pharmacy called magic mouthwash. And magic mouthwash is, what are the active ingredients? What's the main active ingredient? Lidocaine. Right, because that's an anesthetic and it numbs the mouth. And then they'll put in maybe some Benadryl, maybe some nystatin. What's nystatin? Antifungal, used for thrush, candida. Maybe some Mylanta to coat the mouth, maybe some Benadryl, etc. Main thing is, so when do you give it? You give it 30 minutes before meals so that the patient can have pain relief of their sore mouth to help them to eat and get better nutrition. But stage 4 stomatitis, sometimes, they can't even swallow their own saliva. It's nasty. Very painful, and it can affect nutrition and hydration, and they can get infected. Okay? So stomatitis needs to be monitored for and managed aggressively. That's a nursing responsibility. Nutrition can be a problem. If somebody's going to have a lot of problems with stomatitis, they may need to see a dietitian, get supplemental feedings, or some kind of other things to give them protein and calories, etc. How do you know that someone's getting adequate calories? We'll go into the next one, anorexia, which means maintaining a stable weight. It doesn't tell you if they're getting enough protein, but it just tells you they're getting adequate calories. So we want them to maintain a stable weight throughout their chemo treatment. And again, dietary consults can help. Sometimes people with anorexia, it's certain foods that they can't tolerate. They don't want spicy or greasy foods. Maybe they can, drink some of the supplements on ice or eat appetizing small meals. I've seen patients where, you saw the guy with the radiation therapy of the head and neck, and he actually had a G-tube placed temporarily because he was getting a lot of radiation. It was affecting his ability to swallow. So anorexia. There's a drug called Megace that you might see used. It's a hormonal treatment, and it increases appetite. So you'll see it in HIV and other diseases where people have a lot of anorexia. Megace can be used for that. Along with medicinal marijuana, which is also an antiemetic. And people have prescriptions, and now they're going to have prescriptions in DC. So now they're trying to figure out how to manage those prescriptions. So the munchies is a benefit, and so is the mild anti-emesis. Now, Marinol is a drug for anti-emesis. We just talked mostly about Zofran. There is one called Marinol, which is THC, tetrahydrocannabinol, or ganja, whatever you want to call it. And it is antiemetic. It's not as antiemetic as Zofran, but it does work. And then there's the older drugs. There's compazine and phentermine and all those things, which I was told by a pharmacist just makes them sleepy so they don't care that they're nauseated, that they aren't really very good drugs. But we still have those out there. And reglanzapine, metoclopramide, that increases GI motility. That's why we use metoclopramide for people with enteral feedings with high tube feeding residuals. Okay, so there are drugs we can give for nausea and vomiting. I just focused on Zofran because if somebody's getting chemo, they should have the good stuff. They should get the good stuff. They should get the Zofran, even though it's expensive. Okay, diarrhea, of course, there are anti-diarrheal drugs like Imodium. Opiates, there was an old drug called detoxified tincture of opium. Opiates will slow down the GI tract, that's why they're constipating, and in some cases they may use some of that if it's severe diarrhea. And then dehydration, they may need IV fluids, or they need good oral hydration. You can use the Gatorade or the Pedialyte or those kinds of things if they're really dry. Okay? So the nursing interventions and the patient teaching around GI side effects, and all that is on your little, your 261 there, your little chart. You do want to understand the timing of the antiemetics. If they're PRN, then you need to know when they were given last, and you need to use them. Okay. Okay, neurotoxicity. What category of chemo drug are we talking now with peripheral neuropathy? The plant alkaloids, right, the V drugs, vincristine, vinblastine, vinvestine, BP16. So people need to know about the side effect, what to report, what to watch for. If they get paresthesias, if they get weakness, if they get constipation, they need to report it to the nurse. Another thing that's been studied a lot by the Oncology Nursing Society, which has a really good research-based you know, you can get your PhD now in oncology nursing and do research. The ONS has done a lot of research on chemo brain. The patients have complained about it for years, especially if they're taking big drugs like adriamycin, where they say that, you know, they think it's toxic to their brain and they feel a little fuzzy and they have trouble with short-term memory and, you know, just general stuff like that. And the doctors kind of poo-pooed it, but the nurses have done a lot of research, and now you're starting to see articles in AJN, you know, American Journal of Nursing. Some of the oncologists are picking it up. I had a boss at Greater Southeast who had early stage premenopausal breast cancer, and she had lumpectomy, radiation therapy, and then she had adjuvant chemo, and she said after she had adriamycin, which she may have not even needed, now they're looking at that more carefully with genomics, that she's never quite been right neurologically since. That she has some memory problems, some word finding problems, some fatigue problems, etc. So it's not, when people complain of things, we need to listen, and then we need to do research, because it could be a safety issue. Alopecia, what would be your nursing diagnosis? It's related to body image, right? Altered body image. Related to, in this case, temporary loss of hair. So that's one of the things we make sure patients know, that their hair's going to fall out, but it's going to come back. Sometimes a different texture, a different color. You know, it was brown and straight, and now it's gray and curly because of the damage to the hair follicles. But it does grow back. Now, I had a friend who was a nurse who had later stage Hodgkin's disease treatment, and her hair came back from her chop, from her chemo, but where they did the radiation to the base of her brain, that was permanent hair loss. So she had hair above it that came back, and she just combed it over the part where she had the permanent hair loss, and you couldn't tell. But chemo alopecia, the hair will grow back. So people can cut it, get scarves, wigs. Some people these days, I guess, bald is in style, and they don't do anything. Even some women. Now, when the hair falls out on the head, it also falls out everywhere else. So the pubic hair, the eyebrows, the eyelashes, everything goes. And then it will grow back over a period of weeks or months, right? That's what we tell people. All right, so as nurses, we are always going to use the nursing process, which means you have very good, thorough, subjective and objective database. You're checking people's mouths, you're checking people's backs, you're checking people's feet, those kind of things, so that you can predict, prevent, and manage complications. Yes?
Going back to the neurotoxicity,
Yes.
what were the nursing interventions for that again? Just besides
Well, you know, make sure the
assessment?
patient knows, there's patient teaching. If somebody has any kind of neurotoxicity, what top priority nursing diagnosis would come to your head?
Well, neuro assessment.
Risk for injury. Risk for injury. If they have weak legs, what are they at risk for? Falls. If they have problems with level of consciousness or memory or cognitive changes, then they're again risk for injury, etc. So there's always a safety thing when you talk about neuro. I would think safety and risk for injury. Good question. All right. Mr. Armstrong, if you would click on radiation therapy, we will do that. Any questions about cancer chemotherapy, nursing management? Read everything that's in your study guide. Okay. And we're going to move on. Lovely. I like the way you set that up. That's cool. All right, so now for page, I guess you still have all the competency 12 objectives and such. Starting with page 267. Page 267 talks about external radiation and patient teaching. Page 268 is the internal radiation therapy or brachytherapy protocol that Alvina Bass and I wrote at Greater Southeast when we were doing that. We were starting brachytherapy. A former chair of our nursing department had brachytherapy for uterine cancer at Howard University Hospital. They have a big radiation oncology service there. She gave me page 269 when she had her radiation implants for her uterine cancer. Page 270 talks about complications of radiation therapy. You can see areas that are very radiation sensitive, like the skin. Page 271 has the stages of skin reaction. We talked a little bit about this when we did the video on nursing management and radiation therapy. But the two major side effects that everybody gets, or hopefully minimized, but could get, is with external radiation therapy would be skin reactions, because you're going through the skin to get to that organ or that tumor, and fatigue. Everybody gets fatigue, and it's cumulative over the weeks or months that they're getting the treatment. Okay. So you don't need to memorize the dose of radiation therapy that causes these particular problems. But you can see that radiation therapy can affect the skin, the hair, the teeth, the mouth, the tongue, the larynx, the thyroid, etc., etc. And in some places, some things are very sensitive. The hair is very sensitive. Loss of hair in the treatment area. So the other thing is with radiation therapy, the toxicity or the side effect depends on where the radiation is being delivered. If you're getting radiation to the breast, there may be some lung tissue in the field, and that may get some radiation pneumonitis. That's not going to give you anything with your urinary system or your bowel because it's not in the field. If you're getting radiation to the prostate, it could affect the rectum, the bowel, the bladder. It's not going to affect the lungs. Okay. Page 272 talks about the skin. The last page in your study guide is page 273. Oh, yeah. And it's taken from a med-surg nursing book, and it has everything on one page. So I'm a big fan of one-page handouts. It says nursing responsibilities for either external or internal radiation therapy. Last page of your study. And then it does external radiation, which is the most common type of radiation therapy. And it talks about the nursing responsibilities and the patient teaching. Then, on the same page, it says internal radiation, tells you what radiotherapy is, the nursing responsibilities, and the last bullets there are the patient teaching. So, that's it. That's all you need to know. No, anyway. So let me go through the slides with you, but I really recommend that you read what's in the study guide, okay? And that's a nice one because it covers kind of the whole territory on one piece of paper. The writing's small, but it's all in one page. I want my coffee though. Okay. So radiation therapy. Radiation therapy, of course, is a treatment. We have diagnostic radiology. We take people down for x-rays and such and various other imaging to diagnose things. And cancer patients get a lot of diagnostic imaging for their diagnosis, following their disease or metastatic workups, etc. But this is now a treatment. So we're going to give a tumoricidal dose of ionizing radiation to the tumor. And it's toxic. It causes cell death, or tumoricidal, same thing. The exposed cells are killed. Now what they do in traditional external radiation therapy is they give it in small doses over a long period of time. They call it fractionization. And these small doses are to minimize damage to normal tissue. They don't want to zap it with a whole high dose at once. There are some protocols where it's shorter and higher dose, but traditionally external radiation is given. They go 5 days a week, they get the same small dose every day, weekends off to rest their cells, also so that people that work in radiation oncology don't ever have to work weekends. I'm kidding. There is a radiation oncology emergency called spinal cord compression. So if somebody has spinal mets, that'll actually get the radiation oncologist in on the weekend, check the patient. Otherwise, it's Monday through Friday. And they always put them in the basement with lead-lined walls. Anyway, because lead is the only thing that can protect from radiation. The two major types are external and internal. We also call external radiation teletherapy, and the source of radiation is outside the body. So the patient lies under the machine, usually a linear accelerator. They've already had the area marked in what they call simulation by the radiation oncologist and the radiation physicist. And then for that minute or minute and a half while the machine's on, they're getting their dose of radiation therapy. Machine shuts off and they walk out of the department or back up to the room or home or wherever they go. And they do not glow when they leave. So is there any radiation exposure to any patient that you're caring for who's getting external radiation therapy? No. And the joke is, unless you're lying between the patient and the machine while it's on, which nobody does, don't get you wouldn't get any radiation exposure in external radiation therapy. Okay? The techs will set them up, leave the room, they have closed circuit TV, they're on the other side of the lead walls. Okay? When the machine shuts off, that's it. And then they go back into the room. There's nothing hanging around after the machine's turned off. Brachytherapy is a slightly different situation. Now, there's the implants or the sealed sources, which is mostly what we do. And then there's the soluble isotopes. The only one I've ever seen is radioactive iodine, used for thyroid cancer or hyperthyroidism unresponsive to meds or surgery. Okay, so they could drink the I-131, it would circulate through their body and go to their thyroid, because we know that the thyroid takes up iodine selectively. There would be radioactive iodine, that's internal radiation. Usually they're the sealed implants, solid isotopes implanted within or right up against the tumor. Okay, so that's what this says about soluble isotopes. Radioactive iodine, the isotopes excreted. Every radioactive isotope has what we call a half-life, where after a certain number of minutes, hours, days, it's no longer radioactive. It's lost it. Until excretion, the isotope is potentially dangerous to others. So when we have I-131 patients, we would bring them in the hospital, put them in a private room at the end of the hall with a radiation danger sign on the door, and they would stay in there until the half-life had expired. Then they could go home. They actually brought in somebody with a Geiger counter, usually a radiologist, who's the radiation safety officer in most places, and they would actually go around to make sure there was nothing left behind. These are the only patients where the excrement is considered potentially radioactive. And they would double flush the toilet and handle the linens especially. You really don't need to handle the excreta separately, which we'll talk about in a second, for the sealed isotopes. It's been used for 40, 50 years. I remember as a nursing student working with radium implant patients for cervical cancer, cancer of the uterine cervix. They were in a private room at the end of the hall. They put in this applicator. Actually, that picture's not correct. Jenna's trying to be fancy. It's really just an applicator. It goes into the cervix, and they come up from radiation therapy with this little lead-lined container, looks like a little space capsule on a dolly, called a pig. And they would open it up, and there was the long-handled forceps. They'd pull out the radium and slide it up into the applicator, which was already up in the woman's cervix. And then for 48 to 72 hours, she'd be on bed rest, stay there in bed rest, with a Foley catheter, so she didn't have to get up to pee, sometimes on a low residue diet, so she didn't poop, and be there by herself. Nobody holds her hand when you have internal radiation in place, until the half-life has expired. We would use the principles of time, distance, and shielding to protect ourselves from radiation exposure. We wore radiation film badges that were just for us. Everybody gets their own film badge. Okay, so I'm getting ahead of myself. But that's what the radium implants were. The devices, the radium implants for cervical cancer, they would come up in 72 hours, take it out, put it back in the lead-lined container and leave. And then the woman could go home. For the prostate cancer patients, for the beads and seeds they put in now, even for early stage prostate cancer, it's found to be curative and they don't have to go through the radical prostatectomy, which made a lot of men impotent and sometimes even incontinent. They like these little beads. They put them in, they go home, they tell them, don't let your grandkids sit on your lap, don't have sex with your wife, don't let your pregnant daughter get within a certain number, and then in a day or two, they just leave them in because they're no longer radioactive. So that's been a very good treatment for prostate cancer. Oops. Okay, no, that's right. Okay, so external radiation teletherapy, the radiation is external to the patient. The patient is no danger to others. Repeated small doses are given, attacking malignant cells at all parts of the cell cycle. The tumor area is delineated, marked, something purple or black or tattooed. Also had a little patient at Greater Southeast up on the oncology unit. He came back for his first radiation therapy session, which he was getting brain radiation for lung cancer with brain metastasis. And he came out of the bathroom and he was so proud of himself. And he said, I had to scrub and scrub, but I got all those marks off my head. So the next day, he had to go down and start all over, and they had to remark the treatment portal area with a gentian violet or whatever. So the take-home message about this is if you're the nurse, the tech, the family member, the patient, don't wash off the marks. You may see patients years later where you can see where they had their radiation therapy, maybe to their breast, for example, because those marks might still be there. Just leave them there. Okay, patient needs to be in exactly the same position each time. So if it's a child or somebody a little confused, they can build these little immobilizers to hold them in place so they don't wiggle around while the machine is turned on, while they're getting their radiation therapy. Interesting statistic, it's used in 50 to 60% of all cancer patients. It may be used as a curative treatment for something like early stage Hodgkin's disease. It may be used adjuvantly, like after a lumpectomy, to eradicate any possible mets that are outside the treatment area. It may be used for control of the disease. It may be used for palliation. They'll use palliative radiation therapy too, to make people more comfortable. So in Hodgkin's and prostate cancer, there are diseases where they're using it now as a primary curative treatment. So here's what we just said. Sometimes they'll get preoperative radiation to shrink the tumor. They used to do that with breast cancer protocols. Slightly larger tumor, as long as it wasn't spread to the axillary nodes, they would do pre-op radiation, shrink it down so they could then qualify for a lumpectomy. Post-ops used a lot, like I said, adjuvant radiation after something like a lumpectomy, for example. Palliation, which is really the same thing as late-stage comfort care, quality of life. Okay. Now, I'm just going to go through really quickly and talk about some uses of radiation therapy. That's not really nursing. So I just want to give you a sense of the cancers they use radiation therapy for, but then I want to get to the nursing interventions. Okay. We did talk about brain tumors, and I did mention, or we did mention, the radiosurgery. The Gamma knife, the Cyber knife, the Linac, some of these, they're really radiation therapy. They call them knives, but they're actually in the neuroradiology or the neuro-oncology services. They'll take them to the neuroscience area at, say, hospital center where they have this equipment. All the major cancer centers have this, Hopkins, Maryland, Georgetown Hospital Center. And they can go in with radiation. It's not actually a knife, it's a radiosurgery, and they'll be able to get to surgically inaccessible tumors and some other types of tumors that are radiosensitive. So they'll use that for brain tumors. They can also use the traditional external radiation. Like I said, the guy that had brain mets with the lung cancer, and they were radiating the brain metastasis with a linear accelerator. Particle accelerator is pretty much the same thing. And then there are some brachytherapy protocols. That sees a lot of the head and neck stuff.
Well,
and brain.
On the Gamma knife, at the University of Maryland, one of the big things that they're doing now is that they're not necessarily going to radiate, they're not going in to radiate the tumor. What they're looking for is that they're looking for the stalk that feeds the supply to the tumor. And so they try to get to the blood supply. You cut the blood supply off, the tumor will die and wilt away and go away. So the Gamma knife there at the University of Maryland, which there's a headpiece that fits on, which is what you see going across the patient's face. They'll come into the OR and have that put on because they're bolts that go into the patient's skull that have to be twisted
like a
in.
halo.
Yeah, and they have to have this halo on,
Yeah.
and it's these big bolts that go in through their skin, through their skull. It's not a very, very nice thing to have put on because you're kind of awake when they do this.
Oh yeah.
But they're looking for the feeder source that's feeding the tumor. That's why they're calling it a knife, because if you can cut the source, then the tumors will away. Unless there's, too many to really talk about. But some people, they have one big mass. That's what they're really going for with the Gamma knife now.
Okay. And it makes sense because remember, you're trying to get the best patient outcome. And if something's not surgically resectable with a craniotomy, which may cause more problems than the radiation therapy would, it's a really nice, elegant kind of treatment for those patients that qualify, for those small percentage of people that meet all those criteria. Okay, thank you. Also can use RT radiation therapy for intraocular. I worked with a woman at the cancer center, a nurse who had intraocular melanoma. And she had had some radiation therapy. She had also ended up then having the enucleation because of her intraocular melanoma. Nasal and sinus surgeries, oral surgeries, cancers, nasal, sinus, oral, laryngeal cancers, some of those head and neck cancers, they can use radiation therapy sometimes very successfully, particularly in early stages. Of course, all cancers, you are looking for early stages and better outcomes. But that can sometimes prevent some of the radical surgeries of the past that you don't see as much anymore. I think you've seen some, but these radical neck dissections, where huge chunks of their mouth, their neck, etc., were removed, can be very aggressive surgeries. Okay. Not so much for GI. Again, there are side effects if the GI system is affected. So it only says palliation, adjunct to surgery, palliative, bowel obstructions, etc. Usually it's more likely to be surgery and chemo for the GI cancers. Prostate, used a lot now. Used as an alternative to surgery, along with radical prostatectomy if it's malignant or if it's metastasized. At the bottom it says interstitial brachytherapy. The seed implantation for early stage prostate cancer instead of radical prostatectomy has become much more of a mainstream treatment and works really well. Okay, testicular, again, that's really chemosensitive, so you'll usually see combination chemo, but it's very sensitive to radiation as well, and they may need to be able to do the lymph nodes, so they don't have to take them out. The reproductive, the endometrial, the cervical cancer, as I said, they've been doing brachytherapy with radium implants for years. The radium implant brachytherapy can treat the cervical or endometrial cancers successfully, sometimes as effectively as a radical hysterectomy. Ovarian cancer, not so much, but they can use the intercavitary sometimes. Howard University Hospital, Howard University Medical Center in DC, actually has intraoperative radiation therapy. And so I'm sure other medical centers do too, but they can shrink the tumor while the patient's open on the table in the OR, which is kind of a cool idea. For something like abdominal metastasis, for example. Yeah.
If you're having radiation done to your reproductive system, is that chances are you're going to be sterile after
If
that?
they're giving it to the ovaries and or the testes, that would cause sterility.
But what if it was like on the cervix or in the uterus?
Not necessarily. They can also protect the gonads, the ovaries and the testicles with lead shielding. So they can shield the areas that they're trying to protect from the radiation exposure. Frankly, I've never seen a premenopausal woman with the radium implants. We were usually a little older, but might be a problem to do it that way if she was going to be getting pregnant soon. And especially if she was pregnant. Nobody pregnant can get radiation therapy while they're pregnant. Okay, but yeah, usually those were older women. Bone cancer, lung cancer, skin cancer, not so much skin. That's more likely to just cause problems. But pre-op shrinking a tumor, bone metastasis, some of those kinds of reasons they could give it. All right, so the side effects are determined by the size and location of the treatment area, the type of radiation therapy they're being delivered, the dose of the radiation therapy, which is measured in RADS, radiation absorbed dose, how much they're getting daily and how much their total cumulative dose will be over the course of the treatment, and other organs in the treatment area. Again, only the organs that are in the treatment field will be affected, but, if you're doing breast radiation, you have a section of lung in the field, that's an important thing to monitor. If patients have comorbid diseases like diabetes, autoimmune disorders, it may affect healing of skin and skin damage. Medications they might be taking, like corticosteroids, change the skin too, don't they? And they can affect the immune system. If it's given concurrently with chemo, it may potentiate the side effects. So they'll usually, say the woman has breast cancer, she's had a mastectomy, they'll wait till she can comfortably raise her arm above her head, then they'll give radiation to the axillary nodes and the remaining breast tissue. After that's finished, they'll give the adjuvant chemotherapy, sometimes followed then by hormones. Okay. So They try not to do it at the same time, but sometimes they need to. Fatigue, we talked about this, usually begins after several weeks of therapy, may last for months. Patients need to know this is going to happen and that they need frequent rest periods and that they need to ask for help. Okay? Asking for help. That can be hard for some of us. We have patients that go to work, then they go to radiation therapy, then they go home and take care of their kids. First week, that's working great for them. By week 3 or 4, it's like, wait a minute, something's got to give. So maybe they need to take off work. Or maybe they need to get somebody to help them with the kids. Or both. Okay, skin reactions. You do have an article in your study guide. Let me talk about the acute reactions first, because you do have the levels of skin reaction. They can have some itching, dryness. They can also have erythema, the first level, skin change in the treatment area. What's that? Redness, maybe a little swelling and redness. Then they can get what we call desquamation. Dry desquamation is scaliness. So the skin has begun to break down, but it's scaly and dry. Next level, worse, is wet desquamation or moist desquamation. Now it's not just scaling, but it's weeping. And then they can have permanent loss of hair follicles, etc. Some permanent scarring where it gets dry and shiny and tight, and it's scar tissue. Okay, so those can happen acutely. There are medications that the doctor can prescribe, but what do we teach the patient who's getting radiation therapy about protecting their skin? Okay, don't use any of your own lotions, deodorants, anything with perfume, any of that stuff. Okay? Don't go in the sun. What else? What fabric? Cotton, you want to breathe. Nothing tight or constrictive, nothing with elastic. Okay, you want to baby that skin. They'll say padded dry. Some places they'll say don't use any soap. Just padded dry, use tepid water, nothing too hot, nothing too cold. Yeah, no sun lamps, no out in the sun, sunbathing. That area needs to be protected. As I said, there are prescriptions for desquamation, but those would be from a radiation oncologist or the nurse practitioner. Okay, long-term, people can get fibrosis, which is scarring. They can get these spider veins. There's a couple words for this. The one that they use for oncology is telangiectasis, which is the same thing as caput medusa, which is the same thing as spider veins. They're where the little capillaries break, and they get these little, caput medusa is the spider, you know, Medusa's hair in Greek mythology. Telangiectasis is basically the same thing. Okay, little broken blood vessels in the area of treatment. They can have some pigment changes, maybe get darker skin or something like that, and then hair loss. And if it's permanent, if it is in the treatment area and the hair follicles are perfectly damaged, that area would have permanent hair loss. Okay, other side effects. We talked about this in lab too. With the head and neck radiation, they can have taste alterations, they can get thrush, which is a fungal infection, oral candidiasis, laryngitis, nutritional problems if they're having problems swallowing. The white tongue there is the candida, thrush. If the chest and mediastinum's in the treatment area, they could have pharyngitis, esophagitis, nausea and vomiting. If the bowel is in the area, there could be some bowel damage. If the pelvis is being radiated, they could have rectal irritation, diarrhea, problems with urinary frequency, problems with vaginal irritation or stricture, and possible impotence. If the brain is affected, they could have headaches, somnolence, which is, lethargy, which is sleepiness, lethargy, fatigue. Head and neck, they could have xerostomia, which is the fancy word for dry mouth. We talked about that. They can have problems with tooth decay. If you don't have saliva, you're at increased risk of cavities. Difficulty speaking, swallowing, nutritional deficits. They can have stomatitis, which is mucositis in the mouth or anywhere else in that mucous membrane. And they could even have bone effects, what we call bony necrosis, even years later, if it's in the treatment area. Now, for internal radiation, the important thing, which if you were in the radiography program here, this would be burned into your brain. We want to prevent exposure to the people delivering the treatment. If it's brachytherapy, the nurses are wearing the radiation dosimeter to measure the amount of exposure over a period of time. Okay? You can only use your dosimeter, you can't use somebody else's. The reason they didn't let the students take care of the radiotherapy patients when I had them in the Greater Southeast was because they were too cheap to buy everybody a film badge. Only the people that work with those patients. And you want to have decreased time. Patients need to know this. You're going to go in, do what you need to do, and come out. You want to have increased distance, what we call the inverse square law. The further back you stand, the less exposure. And then you want to have shielding. We put lead shields between the patient's bed and the door, so we can talk to them and do some things from the other side of the lead shield. Do you go around the shield and take care of the patient? Yes. We did not have pregnant nurses taking care of the radiotherapy patients. We had the men and the old ladies like me. But when they weren't pregnant anymore, then they could. Very, 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 very small amount of exposure. I never saw anything on any of my film badges when I was doing it, and I was young. I wasn't pregnant, but I was young taking care of these patients. I never saw anything. Does the radiation film badge protect you from exposure? No. You know, the more exposure would be the tech pushing the portable chest x-ray machine around the hospital all day. They have lead aprons that they wear. They have to wrap all the way around you, otherwise as soon as you turn to the side, they're useless. But they're at much more risk working in x-ray departments or pushing the portable chest x-ray machine around than anybody taking occasional care of somebody with radiotherapy. Okay? Very low radiation. They told us at Greater Southeast, the radiation oncologist who came from Howard University Hospital, oh no, these are elective patients, they're self-care, blah, blah, blah. First guy that we admitted with a radiotherapy treatment came up, elevator door opened, and he's in a posy vest. Now, we don't use posy vests anymore, but this was when we tied people down a lot with posy vests. And we thought, wait a minute, it's supposed to be self-care. We're not going to go in there and hang around with this guy. Well, he turned out to be pretty much alert and oriented and cooperative, so it turned out to be all right. But the nurses were nervous enough about these patients, and now we got a guy in a posy vest. But anyway, it worked. He was actually self-care. It was okay. So the marks must be left in place for the skin. Here's some things to do: nursing management, patient teaching, avoid the sun, prevent infection, gentle cleansing. They can get medication if they have desquamation. And of course, is it painful? Yes. You manage the patient's pain always. Here's for nutritional deficits. You want to know their weight. You want to know their intake and output related to fluid balance. You can use a G-tube if necessary, and a nutritionist or a dietitian. For the oral candidiasis, soft toothbrush, good hygiene, antifungal medication like nystatin, swish and spit. Laryngitis, avoid smoking or alcohol, which is kind of a joke because that's how a lot of those guys got laryngitis. Big drinkers and smokers. Smoking, of course, is a risk factor for this kind of cancer. Nausea and vomiting, the antiemetics, you know, the light, gentle foods that aren't too hard to eat. Bowel damage, treat diarrhea, observe for bowel obstruction. If they start having vomiting and things aren't going through, they need to have that checked out. Urinary frequency, check for UTI, increased fluid intake. You can treat it with Detrol to help empty better. That's the generic name. Pyridium, of course, is a urinary anesthetic. So it's for the pain, the dysuria, and it makes everything orange, right? You've ever had it. Sitz baths, local steroids for rectal irritation, medications or implants for impotence if it becomes a long-term problem. You saw the lady with the pelvic lymphoma. You can use water-soluble lubricants or even dilation, vaginal dilation. Here's the headaches from radiation therapy that affects the brain, low-dose steroids. Usually it resolves, so they need to know that that somnolence is temporary. For the head and neck, pre-op assessment, good dental assessment, make sure they don't have any cavities. Obviously, they shouldn't be drinking or using their tobacco in whatever form. They need to try to stop that addictive behavior. Some people can't. I've seen people smoking through their tray. It's not pretty, but they were addicted. Dietary changes for xerostomia. They need to carry water, eat moist, soft foods. They can have the artificial saliva. And then other treatments to prevent cavities. And that's it. So the patient that's got the radium implant, you're taking care of it. What are your 3 principles of avoiding exposure, or minimizing exposure is a better word? Less time, more distance, and less shielding. So you're still going to go in and give the patient her meds, right? Or him if he's getting some other form of radiotherapy. They have needles and beads that they can put into the breast, into the lungs. So there are other different kinds of radiotherapy. But I was thinking of the patient with the radium implant for cervical cancer. So she's on bed rest. She might have some uterine cramping. She might feel that because you got that applicator up through the cervix. So just kind of picture that. So you're going to manage pain. She needs to keep herself busy. Now we have computers, and of course we have televisions and telephones and stuff. But people aren't going to come in and hang out with her. We don't have pregnant visitors. We don't have children visitors. Visiting time is restricted to a small amount of time. What do you do if the patient codes?
Still take care of the patient.
You go to take care of the patient. Thank you. It's not time for a democratic discussion of who's going to take care of the patient. If you're that patient's nurse, of course you're going to take care of the patient. And ideally, the people that are in there normally would have the radiation film badge. Again, I've never seen anybody's film badge positive. The only story I heard was a guy who was a tech, radiology tech, and he left his film badge on the chest x-ray machine for like a week. And every time they did chest x-ray, he was getting, the film badge was collecting data. It wasn't him being exposed, it was the film badge. And so, you know, of course it came out with a dangerously high exposure and they had to investigate. It turned out he wasn't wearing the badge. Anyway. So the patient management, the nursing management of a patient with radiotherapy is very important. Time, distance, and shielding. Less time, more distance, and less shielding will help you protect from exposure. Okay? All right. Questions about radiation therapy? Good. Okay, wait a minute. Let me have you go to one piece of information here. I just want to go through it. Maybe you can come down and bring your test. Page 268, Radiation Safety Precautions for Radiotherapy. Taken from the Oncology Nursing Society Education Manual. Talks about time, distance, and shielding. Talks about restricting visitors. What happens if the radioactive implant comes out of the patient? Well, you can call radiation oncology, but at 3 o'clock in the morning, guess who's going to come? Nobody. So the nurse will take the long-handled forceps that are in the room, pick it up with the forceps, the radiation source, put it back in the lead-lined container, which is also in the room, close the lid, and call radiology. Somebody from radiology will then have to come up and get it, or somebody from radiation oncology. Now, the radiation oncology tends to be a different department, but the radiation safety officer, who's ultimately responsible, is usually a radiologist. Okay? So go through on page 268, the safety precautions for radiotherapy. It talks about the principles. Number 1, time, distance, and shielding. Number 2, it talks about measures for sealed sources like radium implants. It does say something about no private room, no radioactive. Okay, H, under 2, for the sealed sources, no radioactive precautions regarding body fluids. Because it's just a sealed source at the point of the tumor. It's not floating around in the bloodstream. Whereas remember with the radioactive iodine that they have to take orally, and it does go through their bloodstream, those patients would have special handling for their excrement. Okay, and then patient education is number 3, which is really a restatement of what is above it. Okay? So radiation therapy, external, internal. Know the difference, know the nursing management. And you're good to go. All right. And the tests.
Okay, this is how we're going to do this. Miss Brown's group may go ahead and depart. Okay, because we don't have those exams, so we'll have to work that out. Okay? So.
LD6, we'll tell her to show you.
Right.
Got that.
Now, for the other two groups, this is quite a large area, so I think the easiest way for us to do this is this. My 3 LDs, you need to come to this side. Miss Ames' group needs to come to this side, okay? So that we can kind of keep a handle on what's going on, because this is the big area for us to deal with, okay? So if you could just kind of pick up your stuff, kind of get your stuff, and we're going to kind of move quickly. Now remember, you remember the rules. There is no cell